pressure for a global health architecture reform. At the core, this is about how global health systems are financed, governed, coordinated, and who gets included into shaping them, right? Why does this debate, this conversation matter? Does it matter right now?
Yeah, of course it matters. It's one of the key things that the Non-Communicable Disease Alliance first came together to really bring together a wide range of diseases and risk factor organisations, because we all wanted to ensure that non-communicable diseases, in the widest possible sense, was included into that global health architecture. Back in the early 2000s, non-communicable diseases, NCDs, had been left out of the Millennium Development Goals. Very consciously, decisions were taken not to include them. And so we really wanted to see them included in what became the Sustainable Development Goals, and went through a whole process to ensure that happened. And we were very pleased to get our own targets, the SDG 3.4, about a reduction in NCD mortality and promotion of health, mental health and well-being. But, 10 years on, 15 years on from all of that, we've still not really seen a shift either in the global health architecture to deliver that or the financing. So NCDs account for around 75% of global mortality, around 43 million deaths per year. Many of those are happening below the age of 70, when people are in the prime of their productive life. And about over 80% of those premature deaths are happening in low and middle income countries. These aren't just high income country problems. So this epidemiology, this burden of disease, and the demographics of ageing populations in many countries is really shifting. And what's not shifted is that financing and that global health structure to support it. So we are really keen to see that change happen. The other thing that's interesting is that this isn't just about, this abstract thing, global health. This is about how health is delivered at the national level and at the regional level. And we really would like to see the way global systems are set up to support national action, support that national disease burden, and the way priorities are shifting in country. So these disease-specific silos, which were very much set up to deal with really important priorities of infectious diseases and maternal and child health, now begin to evolve and do more to support delivery of health systems that can deliver integrated care that support people and the complications and the multi-morbidities, the complex health issues people face.
So this shift really is about integration, right? It's about moving away from the MDGs and in some sort from the SDGs as well, because as you mentioned, 10, 11 years after the SDGs were adopted, we are still living in and experimenting global health systems that are vertical, not really fitting for purpose, and not really responding to the realities in countries, to the realities of people trying to access to health and care. So how do we get that message to leaders, to policymakers, to decision makers about exactly this shift? How good a health system look like in 2026 for NCDs?
So look, it's really interesting because you will hear us talk, and others talk a lot about vertical disease systems, silos, they call them. But let's be clear, these have been very efficient and have done an incredibly good job in delivering real health benefits and saved millions of lives through the work that they've done. But what we're not saying is we now want our own vertical silo for NCDs. That's never what we've been saying. Where the discussions and the dialogue and the politics and the need has shifted is towards much more integrated approaches. So I'd call out two things. First of all, the commitment to the achievement of universal health coverage, the delivery of health to people where they need it, when they need it, without catastrophic financial cost. that they get what they need when they need it. And so there's a whole process around universal health coverage. There is its own SDG 3.8, and we all say these two go together, the NCDs and the UHC one. You can't have one without the other. There'll be a high-level meeting next year in 2027, really looking at the progress on that and what more needs to be done. And so you will see us talking a lot about the need to deliver on that and the different aspects of that, the access to treatment, the financial protection, and extending it to think about prevention as well. So you'll hear us talking a lot about that and how important that is. And another big initiative that we would really support and are engaged with is what's been called the Lusaka Agenda. And this came out of a whole dialogue about the global health initiatives and how they could develop. And the big sort of values or aims behind that, what the Lusaka Agenda is this idea of one plan, one budget, one monitoring and evaluation system. At the moment in countries, governments are having to respond to their different funders down these different silos, have different plans and budgets and different reporting systems to these different funders. And what they're asking for and demanding is a more integrated approach. So they, in countries, set their own priorities, write their own plan and write their own budget. And the funders and the people who can support them and help them deliver their own sustainable domestic financing support their plan, not insist on their own plan. So between these two things, universal health coverage and delivering on the Lusaka Agenda, we could make massive changes for non-communicable diseases. And I keep saying NCDs, and I keep wanting to stress that that's a really wide range of conditions and includes neurological and mental health conditions. So we're talking about the full range. So a big shift could happen with those. So that's why through these discussions about the global health architecture that are happening now, we don't want these to just be about streamlining and better efficiency in these verticals. We're also not saying that we need to rip up those verticals, but we are saying that much more specific effort needs to be made across all the different parts of this architecture for supporting strong health system development that can deliver on person-centred care. And all of the different bits of the architecture can do more for that. And the conversation really needs to look at the gap about what needs to be done to really help that transition happen at the national level, and how can we help governments become more in control of their own health agendas and better support sustainable domestic resource mobilisation.
So this is really about more coordination, looking at people's need holistically, and also supporting countries transitioning from this vertical mindset to this coordinated approach. I would like to touch on communities, the people in need of access to care, people affected by risk factors, all of us, billions affected by air pollution, by tobacco, and others. So this debate, do you think that the voice of civil society is there? Where is taking place? What is happening with that?
So I think, and we all think, civil society is really important in this whole process, and engagement is critical. I was talking about this existing architecture. We need pressure from outside and within to make these changes happen. And people with lived experience of both disease and health inequalities, communities, should have that voice and be at that table. And within the places where the decisions are happening, not just outside and providing sort of input to consultations, they need to be at the table. And so we're quite concerned. There's a WHO proposal going to the World Health Assembly this week. We're in May. And in that proposal, there is no seat in the Joint Task Force for civil society or individuals with lived experience. And we think that's really the wrong thing a signal to be given, and the wrong approach. We really need to make sure that civil society and lived experience, individuals and communities are represented at the table where decisions are happening. So you'll hear us talking a lot about that. And beyond that, within the whole process, as the process evolves and the outcomes it delivers, We want to see, the values which are in the NCD Charter of Meaningful Involvement for Lived Experience really brought to life through this process to really make the difference, to have the voice for change, the voice of the people who receive these health systems be there as they get designed and the plans for them to be delivered.
So this is crystal clear. There can be no reform without people's voices in the decision-making table. Thank you very much.